thank you so much for sticking it out till the very end. That's great, especially after, from what I hear, there was quite some celebration last night. If at 3:25 you could all do that, I'd be eternally grateful, because then I know that it's time for me to shut up almost. And it also means you know how to clap in British Sign Language. So you'll have learnt something, if not from all of the things you've learnt today. I'm afraid my topic is not the most exciting one. You're not really going to learn anything from me. What you're going to have is a revision session. So you've done all your exciting learning today. There's been some fantastic presentations, and I've learnt an awful lot. Yesterday I've learnt the importance of moisturising older skin on the 1st of October and all through the winter. And well, as Jackie Fletcher, keep your glasses close by when you get to a certain age as well. So I'm going to talk about the importance of record keeping, and this isn't specific to leg clubs, this is for all of you, for all of your documentation. And I may be teaching some of you to suck eggs, I'm afraid, or in the case of my breakfast this morning, 2 boiled eggs, but you do, you know, it's always worth a revisit. So let's think about some of the drivers. Well, you are accountable to the patient and to the public for the services you deliver and how you deliver them. The law is driving the fact that you need to do good documentation. You need to keep good documentation, because quite frankly, if you're in front of a judge or indeed in front of the NMC and your records are saying things like normal for Norfolk, as Dr. Cutler was talking about yesterday, or patient appears to be stupid, or whatever value judgment you've made, they're not going to take too kindly to it. Or indeed, we've always done it like this, this is why I've done it. And of course, you're accountable to your employer. Interesting statistic that only 40% of nurses on the NMC register are employed by the NHS. So, you know, other organisations are going to want different types of documentation. So I just want to talk about accountability for a moment. Accountability is an integral part of your practice. There's no getting away from it. You can't be partly accountable, like you can't be partly pregnant. You're either pregnant or you're not. You are accountable or you aren't. And as a registered nurse, you are, according to your NMC code, accountable for your actions while you're in practice. And what you need to remember is that accountability and authority are interdependent. So though a greater degree of accountability is expected of those with greater authority. So when you all nurses started going off taking junior doctors' jobs, like, you know, stripping varicose veins and endoscoping and doing all those sexy things that we decided we wanted to do rather than actually nursing, what they didn't realise that they were filling junior doctor posts, and as such would be held accountable at a junior doctor level. So you have to think about these things in terms of how you set yourself up in terms of being specialists, etc. You're accountable to the patient. You're answerable and responsible for the outcomes of your professional action. So we need to make sure that our wound care is appropriate. We need to make sure that we are using the right dressing, that we're confident that the dressings we're using are the correct dressings for that particular wound, for that particular patient. You know, issues like, do you ask all of your patients whether they're vegetarian or not? Anybody ask whether your patient's vegetarian? Are you thinking I've gone mad now? That's a strong possibility, but why would you ask a patient that? Yeah, hydrocolloids. Or if they've got a thyroid problem for iodine dressings and things. You know, these are things you kind of need to think about. And making sure that you know the action of dressings rather than, you know, somebody comes along one day, puts one dressing on, another one comes along 2 days later and puts another one on. You've got a legal and professional duty to ensure that the care you give for your patient was given to a certain standard and in accordance with guidelines. That's why your organisations spend endless hours at policy committees and things. They are producing guidelines that you need to work within. And if you don't work within these, you're unlikely to be covered vicariously by your organisation. Did you know the word vicarious, or the word vicar, comes from vicarious? I learnt this from Bill Bryson. The man is a genius. Apparently vicars vicariously used to stand in for priests who were on holiday or ill, and that's where it comes from. So you've learned something that's non-clinical today. And sometimes, it does feel a little bit like that with our patients, but not really. No, we are accountable to the public. We've got to provide a service for which we're employed and use resources appropriately to provide that service. So again, that is about thinking about the dressings you're using, the fact that actually when you're on night duty, if you have time, you don't go home with a pen or all those sorts of things that we used to do, or write letters during the night. Those were the days. I remember that. It's too busy now. And again, if you deliberately or recklessly cause injury to a patient, then you may face charges under criminal law, and you might find yourself in court. Similarly, if you commit a crime, the NMC would say that you're not serving the interests of society. So, we're also accountable to the law, the civil law, and this is where we have a duty to the public to ensure that we don't harm them while they're in our care. And negligence, all the cases of negligence arrive from poor care. Now, I've recently did a Google search on solicitors and pressure ulcers and compensation claims, and you really wouldn't believe the amounts that patients and carers and relatives are being paid now when something goes wrong in terms of patients developing pressure ulcers. I'm sure this will start applying to leg ulcers. Can you hear me? All right. Better? It will start applying to other conditions as well. So we need to be very careful about the care we're giving and making sure it's timely and appropriate. In terms of criminal law, we're not allowed to harm patients intentionally. And again, I'm sure none of us do. I know we've heard cases where this has happened, but you have to think about your actions. Are you up to date? Because if you're not, you could be perceived as intentionally harming the patient through your act or through your omission. And I think that's as important as what you do. It's what you don't do that can have consequences. And of course, if you assault a patient, you can be prosecuted, and assault can actually happen as a result of not giving consent or not obtaining consent. And of course, we are bound by employment law. We work within guidelines, policies, procedures, and as I said previously, if we work outside of these, we'll lose vicarious liability. Although, of course, we now have to have personal indemnity. I'm sure you're all aware of that. The RCN, the NMC have said that we all need to be personally indemnified for our practice. So if you're in the RCN, you should be all right. If you're working outside of that, you need to think about how you're covered.
You mean NHS?
Sorry, the NHS, I beg your pardon, if you're working outside the NHS. So if this is you on a Saturday night, that's not really, or indeed after last night, from some people, not saying anything, not pointing at anybody. The public have an expectation of what nurses do, rightly or wrongly. They still expect us to be ministering angels, and they don't really like the thought that we might look like that. That's a London squirrel. It's probably not a Devon squirrel. So, when we have a contract with our employer, it carries an inherent assumption that we're going to adhere to our policies, etc., and also adhere to local and national guidelines. But we've already heard today that's really difficult because we've got 3 types of skin tear assessment. We've got, do we use category, do we use grade, do we use stage for pressure ulcers? I can guarantee that all 3 are used in this room. But the fact is, are they all saying the same thing? Now, EPUAP would argue that category is different to staging, is different to grading. And that's why they changed it. But then we'd need a sea change amongst many people to go from staging or grading. Similarly, most of us use Waterlow for pressure ulcer assessment, don't we? Because we think it's simple. Actually, it's probably one of the worst tools to use because it over-predicts and under-predicts. But actually, that's the one most people use. Are we going to change everybody's opinion? I think the thing is, as long as you all use the same tool within the organisation, and when you discharge patients into the community and vice versa, it's basically singing from the same hymn sheet. As long as you all understand what it means, that's fine. We've got to use resources appropriately. Again, this is what happens when you don't use resources appropriately. So let's think about, I'm going to get onto the topic of documentation now, finally. Clinical governance is important. It's not talked about so much anymore, but it is still an integral part of the NHS. And it's a system through which NHS organisations are accountable for continuously improving the quality of their services and safeguarding standards of care. And that's by creating an environment in which excellence in care will flourish. Now, I'm sure a lot of you in here will argue that your organisation doesn't necessarily help that. And sometimes, you know, when you are trying to set up a lake club, for example, there is a lot of banging your head against a brick wall because it's not the immediate benefits or the clinical outcomes are not seen. So sometimes it feels like you're battling against your organisation. But they have a duty to the communities they serve for maintaining quality and safety of care. And whatever structures and systems and processes are in place, the organisation has to show evidence that these standards are upheld. And this is done by clinical audit, evidence-based practice, any clinical supervision and reflection. How many of you get formal clinical supervision? A couple of people. Are you not in mental health by any chance, are you? No. I think clinical supervision came and went very quickly for general nurses. I think they suddenly realised that unless it was group supervision, it was going to be extremely costly, time-consuming, and perhaps a bit of a waste. So it quietly went away, which is interesting. We maintain standards through research. We've got to make sure the care we're giving has the right outcomes. And we also use complaints, critical incident reporting, investigations, root cause analysis to help us see where things have gone wrong and to see where we need to improve. Do you all get results from root cause analysis? Because what I've found a lot is, you know, we do these RCAs, spend a lot of time doing them, and nobody gets any feedback as to what the outcome was. Or, you know, looks at themes. There's certainly nationally, there's no themes emerging from RCAs, which I think is a real learning opportunity lost. And all of these standards are underpinned by professional self-regulation, strong leadership, effective communication, stroke documentation, a commitment to quality, and our continuing professional development, whatever form that takes from the NMC's ideas. So, I'm not very keen on flying myself, and certainly wouldn't want to be in a situation like this. But the good thing about planes is they have an orange box, or a black box. It's commonly called the black box, and it has one of those in the cockpit and one in the tail. And the one in the cockpit tends to record all the conversations, so everybody back at base knew which stewardess the pilot slept with the night before. And the one in the back tends to record all the data, all the electronics and etc. In nursing, we don't yet have black boxes. So we have to make sure what we do is recorded properly because it's not being recorded on a black box. Although this is coming in for police recording conversations, stop and search and things. So it's important that we have our documentation because this will help with complaints, clinical governance. It can be used as evidence in court or during legal processes. And obviously we have to do our documentation to NMC standards. So, helps improve accountability. It shows evidence of the services you've delivered. So it shows that you have done something or you haven't done something. You document actually what you've done. it should show how decisions related to patient care were made. So you should really give a rationale as to why you picked a particular dressing, because the wound is highly exuding and a foam is required for X number of days till the exudate is reduced. And again, supporting clinical judgments and decisions. Why did I do this? As a nurse, I should be able to walk into any patient's home or onto any clinical area, pick up a care plan and be able to care for that patient without knowing anything else about them. Could you say that would happen in your organisation? Could I walk into any single one of your organisations and be able to deliver care for any one patient without knowing anything else about them? Because your documentation's really good. Probably not entirely, I would say, but you know, that's probably true for all of us. It should help us identify risk by, you know, you're observing the patient, you should look at observations, look at what might be going wrong, and complications, and it supports continuity of care and, more importantly, communication between professionals. And we are trying to do more teamwork these days. In fact, you know, often documentation is more integrated. Electronic documentation is much more integrated. And I think this is a good thing. You know, the electronic world offers a lot. My father, unfortunately, was taken ill. He was travelling home from London to Blackpool on a bus last week, and just outside Coventry he had fallen asleep and woke up and actually was hallucinating. So it's quite interesting listening to Anita this morning, and he was, you know, quite poorly. He was dehydrated. It all boiled down to dehydration. However, he was whipped off to hospital. The police were very good, whipped him off to hospital. But of course, then they're telling him, oh, we think you've got kidney disease because you've got these, and all sorts of things that they suddenly, you know, had found wrong with him. But his GP knew all of this. And, you know, because they couldn't access any kind of record for him, they made, you know, assumptions about what was wrong with him. So if we could have this kind of let's share everything, life would be much easier. Ellie, I know, I'm sorry, I'm keeping you awake. Okay, so again, documentation, it supports audit, research, allocation of resources and performance planning. I've just done a review of a tissue viability service, and whilst I saw every day that they were working their socks off from morning till night, actually they had so little documentation they could have been doing anything. They recorded wounds as pressure ulcer, leg ulcer, other wound. Now, was the arterial ulcers, venous ulcers mixed? Were these new ulcers? Were these reoccurrences? Nothing, really nothing to demonstrate what they were doing and what their outcomes were. And as a result, of course, their service was under threat because for a lot of the organisation, they didn't know who these people were and what they were doing. So it's so important. Failure to document, well, it's obviously the opposite of why we need documentation. It's likely to lead to clinical accidents and legal claims. Not having time to complete documentation, I'm sorry, is no defence. If I was sitting here with a wig on and had a jury of peers, the fact you are busy from morning till night, you've only got 10 minutes between patients in the community or whatever, you leave your documentation till the end of the day, not good enough. Because I can guarantee that you will not remember everything. I have trouble remembering what I did this morning, so how I would remember my interventions with my patients, I don't know. Again, at this organisation I was at, one day I was given over to running a leg clinic. They were so busy, they took the patient's notes, clinical notes, back to the TV office and wrote them up the next day. Now, if one of them had been run over the night before, what would have happened? Absolute disaster. We wouldn't have known whether that patient had had any care or not. It isn't, and that's not me saying this, there is no excuse for not writing your documentation at the time you're delivering your care. And you need to think about verbal communication as well. You know, how well that's received. Where possible, don't communicate verbally about things. You know, you must write it down if you can, or write what has happened with the verbal communication as soon as possible after that's been received. Now, this comes from a court case, Coles versus Reading, back in 1968, I think, 63. I was so young then. The patient had come to casualty, they'd had a crush injury, and the nurse said to the patient, "Have you had a tetanus?" And the patient said, "Yes." And so the nurse said, "Fine." And off the patient went and subsequently died from tetanus. What she hadn't established was that, you know, had he had his tetanus within the last 10 years, because tetanus only lasts 10 years, you have to have it redone. So the nurse was held accountable for that because she didn't clarify with the patient exactly what she was trying to establish, and he misinterpreted what she had said. And again, same on the telephone, thank you. You've got to ensure that the advice you give or you are given is understood by you and the person you're informing, and that this is then documented. So, this is complete revision, and I hope you recite this to yourself at night before you go to bed. You must keep clear and accurate records of the discussions you have, the assessments you make, the treatment and medicines you give, and the effect. Complete records as soon as possible after an event has occurred. Don't tamper with them in any way. And ensure they're clearly and legibly signed, dated and timed. Again, you can't, you know, if you have agency staff on your ward or in your clinic, you need to make sure you have a copy of their signature plus their name, and you keep that, because quite often negligence cases come 2-3 years after an event, and it's very unlikely that you'd remember who that agency nurse was from a scrawl. So that's really important. And in fact, it's good practice to keep them in your clinical areas anyway. Do you do that? Do you all have copies of signatures? And yes, great. Oh, good. I didn't need to come. And you've got to keep your records securely, of course. And that's not in the boot of a consultant's car on the golf round course. So, make your documentation contemporaneous and clear. Date, time, and sign it. If you can, write it with the patient. I absolutely believe patients really like getting involved in discussing their care and saying, "Oh, put that down," you know. Write them in terms patients can understand, because you know, they can have access to their documentation, and it is about no decision about me without me. So, you know, make sure they know what you're saying. Don't use the jargon. Don't use abbreviations. For example, normal for Norfolk, NFN, or FLK, funny looking kid, all those sorts of things. Don't use meaningless phrases, irrelevant speculation, or offensive subjective statements. I read a ward sister had written that a patient's husband was the village idiot. And she'd written that in the patient's notes. You know, some things have just been ridiculous. And again, you know, you write things like, "This feels consistent with a fall." You don't make a diagnosis. Unless you saw the patient fall over, don't say the patient fell over. You say, "I found the patient in a position consistent with a fall." Don't alter them if you can. And remember, not documented, it's not done as far as a court of law is concerned. You may have given all care for a whole 24 hours with bows on. But unless you've written it, nobody's going to believe you. And similarly, if you state you've done it, please make sure you do it, because otherwise they'll believe you've done it. You need to think about spelling, although of course, you know, it's not that, it is important, it's not the end of the world, but you know, again, it's about perceptions. If a solicitor thinks you can't spell, they're going to think you can't deliver care either, and they'll pick up on that. And again, just as an example, it can have a whole different meaning. Remember, not documented, not done. I emphasise that. And just some bedtime reading. The Ombudsman's reports, Health Service Ombudsman, fantastic. I can guarantee every single complaint that goes to the Ombudsman, documentation is mentioned. Poor documentation is mentioned. But it's interesting to read these. The NMC, if you read there, you know, who's been up before the beak, the NMC, again, generally about documentation. Thank you very much.